Now can you hear? Okay, welcome again.
Thank you.
Can you share your presentation?
Yes, of course.
Now our speaker is Nicolas van der Meulen from Paul Scherrer Institute in Switzerland. He will give a presentation on radiochemistry, target preparation, separation. Good morning, Nick. How are you?
Morning. I'm well. How are you?
Thank you very much. Okay, speech is yours, okay?
Cool. Can you see my screen? Okay. I hope you can see my screen well.
No, we are trying to see.
Okay, let's see if I can switch that. Okay, is that better?
No, we have a problem now.
Oh, okay. All right.
Okay, let us some time. Bir bakar mısınız?
Seni buradan yapmıştık.
Evet ama ha. Oldu mu? Tamam.
Siz yakınca oluyor. We are ready now.
Everything okay?
Yes.
All right. So if you don't, can I begin then? Or am I early?
Okay, we are ready. We are listening to you.
Fantastic. Good morning, ladies and gentlemen. It's a real pleasure to be here at the summer school today. My name is Nick van der Meulen. I'm from PSI in Switzerland, as I've been introduced. And I'm going to give you a bit of background as to basic research of radionuclides to be able to reach the point of clinical application. Some of these points that I will raise today have probably been covered yesterday as well as the day before from some of the lectures that I've heard. So there will be a little bit of overlap, which I hope will be informative. So the concept of why we are here and why we're doing the summer school is to be able to go along and diagnose and treat cancer. And this is where one actually does labeling of a nuclide through to a ligand. The ligand is injected, the tumor picks up the ligand in question, and one can image. And then based on that, one can then be able to treat the compound with another radioligand, and this is then radioligand therapy. So to be able to take this concept, then one would have to rely heavily on the targeting agent because it overexpresses a specific enzyme, which then the ligand in question can come in almost like a Trojan horse with the nuclide in question and then be able to either image or treat accordingly. So the radionuclide is, while it is important, it is as important to have the correct ligand to be able to treat the correct cancer. And so the way we are looking at things now currently, we have the likes of gallium-68 as a radiometal. I know this was covered with the generator, I think, yesterday morning. to be able to go along and do the imaging. And then currently one is treating then using the likes of lutetium-177 and yttrium-90 using beta therapy, and to a degree even actinium-225 with alpha therapy, although this is still something that is coming through to the fore. From our perspective, we're looking at the concept of what we would call, if you like, true theranostics. And this is where one uses the same element to be able to go along and image and treat. So some elements then have the capability of being able to decay where one can image, and that other radioisotope of the same element then will have specific properties to be able to treat. So one can use cyclotrons then to produce some of these radioisotopes. And in this case, we're looking at the likes of your copper-64, scandium-44, terbium-155, and the like. Your blue ones here are indicated by being able to be produced by reactors. And today, I'll probably focus more on terbium-161 than others. And then there are other options as well that are coming through to the fore. If one looks at the EU projects like PrisMap, then one can do online spallation and mass separation, or even offline mass separation. But these topics are very much in its infancy, and I will not cover these today. To be able to go along and get these nuclides out through to clinical application, one has to start from scratch. It requires a great deal of collaboration, because it's a multidisciplinary affair. Each one of us has our own areas of expertise. So when it comes through to target irradiation and irradiation capabilities, we focus very much on the accelerator physicists that will be able to go along and assist us to be able to optimize our irradiation capabilities. We have radiochemistry, which then ensures that your pure product is produced. The quality control ensures that we have a pure product that we can go along and utilize, also with regards to a labeling to a specific ligand. Preclinical studies take that radioligand and be able to test it in an environment such that one can see how effective it is. If the results are promising enough, then it starts reaching the point of clinical application, and that's where one has to then start licensing it for GMP process development, and then prepare a dossier towards a clinical study. So all of this is, and not one person can do this, it requires a whole host of collaboration and working together to be able to ensure its success. And this is a very, very important topic that I think many of us, we are all focused in our little world of where we are, and we actually have to go along and take the big picture into consideration if we ever want to be able to succeed in doing something like this. So the concept of radionuclide development involves target preparation, the irradiation of that target material, depending on which form of irradiation you wish to use, the reaction that you are producing to be able to produce that nuclide, the desired nuclide. You want to have the specific parameters such that it maximizes what you want and it minimizes any other side products that could go along and harm your product. It could harm your patient. You have chemical separation and processing to ensure that your product is pure. And then after that, you can go along and do your labeling and imaging. So that entire cycle comes into play, and I'll try and cover as much of this as I can today. For me, from the world in which I live and work, we focus predominantly on the chemical process application. And what is vital about this is that we have target material that we use for a specific irradiation. And generally that is in milligram quantities, sometimes even gram quantities, depending on the nuclide that needs to be made. And we have to develop processes to ensure that we get the desired nuclide out and have it chemically and radionuclidically pure. And to be able to do this, we use what we call ion exchange chromatography. And these involve resins, different types of resins, anion exchange, cation exchange, extraction resins are very popular nowadays, to be able to go along and ensure that we remove the target material, we get the desired nuclide. So generally the first column that we produce and in a system, in a specific chemical environment, because each chemical environment is different to be able to get what we want. Not all of them are the same. So I will touch on that through this lecture as well. Then you will elute your desired product. The workhorse is your first resin, which takes away your target material, and your second column then generally polishes it up. So basically cleans off all the other nasties, takes out what you desire in terms of your nuclide. And often we use this particularly for when one prepares for preclinical application. In preclinical work, it is very important to have as much nuclide in as little solution as possible. But this whole concept over here from the chemical separation is basically where we want to be able to get our product from our target material. And our product, if we had to weigh it out, I mean, the radioactivity measures very, very high. But if one actually has to go along and weigh out that specific metal, it is very, very low. So it's around about nanograms of product, maybe micrograms of product if we make a lot of activity to separate from milligrams to gram target material. So you can see the scale of 1 to 5,000 that we need to go along and be able to perform the separation. So it's in essence, if one has to go along and picture this, it's almost like trying to extract the needle in the haystack. So taking this concept into consideration, this needle that we extract needs to be absolutely bright and spanking clean. And that in this analogy for radionuclides, it implies then it needs to be chemically pure. So yesterday afternoon, there was a lecture about the chelators having to be metal-free in terms of preparation. While this is very true, it is also vital from the radionuclide perspective that it needs to be metal-free in terms of not having any other metal ions present. So, you know, the things that immediately come to play is the likes of copper, the likes of zinc, etc., and iron that can interfere with your labeling process. So while your chelator then also must not have any metals in it, so too your radionuclide mustn't have metals in it. And then one can then be able to go along and perform your labeling in specific environments. I mean, with your small molecules, you can go along and use higher temperatures, as was stated yesterday afternoon. Generally, everybody tries to focus on being able to label in as short a time as possible at room temperature, if possible. Of course, sometimes this is not the case and it cannot be done, but for antibodies, this is particularly important as well. So taking all of this into consideration, we have to go along and optimize the labeling process, but we also need to ensure that there are no other interfering metals in play here. And this ensures also your chemical purity when you do your labeling. So you label at what we call an apparent molar activity, and the higher apparent molar activity you label at, the better the purity of your radionuclidic product is. So this is what we go along and aim for. You know, if you are able to label at 99%, people get excited because you can label at 99%, and that's great. You can label at 99%, but if you can only label at 99% at, say, 1 megabecquerel per nanomole in terms of apparent molar activity, and you need to have 50 megabecs per nanomole apparent molar activity to be able to apply to a patient, then your purity is not that good. So the higher the apparent molar activity success in terms of labeling, the purer your product is. And of course, then it becomes easier to be able to apply clinically. In our world, we have 118 elements. And the isotopes are about 3,000 of them. Now, if we go along and break down what actually happens here, most of the nuclides that exist, we have to be able to produce artificially. So around about 2,600 out of the 3,000 that exist, we have to produce artificially. And that implies that we take a material and we have to irradiate or impinge particles onto it at almost the speed of light. So we're using a particle accelerator like protons or deuterons. You would then go and use that, and at 2/3 the speed of light, to be able to hit a target, and then that would then make it unstable by throwing off a proton or a neutron, and therefore as a result it will make it unstable and make it radioactive, and then it will try and regain its stability. This is how it is done and produced. But from these artificial radionuclides that exist, we use about 5% of them in existence for radiopharmacy purposes. And of those 5%, 95% is diagnostic and only 5% is therapeutic. And this is what we are trying to go along and improve on now, is just to be able to produce more therapeutic radionuclides and be able to take that through to the patient and to clinical application. Of course, as of late, we are very excited because of all the new nuclides that are coming about. We have the likes of astatine-211 that is hitting the headlines, of course, actinium-225 and lead-212 and terbium-161. So it's very exciting to see these new nuclides come along and hit the market, and to see how we can be able to use this to improve patient quality of life and hopefully be able to go and cure the cancer in question. So our world consists of the Karlsruhe nuclide chart. The nuclide chart then covers everything in terms of the radioisotopes that exist. And you have the positrons, or the neutron poor nuclides, which are then your orange come pink ones. Your yellow ones are your alpha emitters. Your blue ones are then your neutron rich nuclides. And there you can determine the half-life and what its emission capabilities are on this chart. And this is something that we use a great deal. And actually there is an app, an IAEA app, that one can go along and apply to be able to gain access to this very easily. So the forms of decay that come from these nuclides that we focus on a lot for radionuclide for a medical application is alpha decay, obviously, which is basically then, in essence, the decay and the release of a helium nucleus. Alpha decay is it does not penetrate very far, but its energy is particularly high, so it has a devastating effect. So this is also why it is very important to be able to use it in a proper target ligand to be able to then go along and apply towards shattering and destroying a tumor. We have beta minus decay, and this is where neutrons become a proton. So basically the nuclide changes by 1, and I'll show you some pretty pictures, hopefully that can give you an idea of how this works. And then, of course, we have positron decay, and this is generally used then for the diagnostic side of things, which we use then in our radiometal application. So this is pretty much how the decays work in terms of when your mother nuclide decays through to your beta minus, as well as your alpha decay, etc. And so you can actually see then where the with the pictures based on your neutron rich will be your beta minus decay in blue, and your positron decay then in your orangey pink color, and then your yellow color then is your the loss of your helium in alpha decay. We talk about these specific kinds of decay, and when one applies this towards the patient and the being able to work on the tumor, is where what the particle can go along and do in terms of its energy. And this is also was mentioned in terms of the linear energy transfer. And the linear energy transfer then indicates how far this activity can go along and travel. And as you can see then with a beta particle, it can actually travel quite far and generally is focused then on your larger metastases in the cancer patient. Of course, the alpha particle is then aimed at small metastases and then can be able to go along and destroy those with its high linear energy transfer. And now what is being focused on is what they call the conversion and Auger electrons, which also have a high linear energy transfer, but has a very low travel distance. So in essence, then it can focus on your single cancer cells or the ones that you can't necessarily image. This, of course, is still being focused on as a how can you say, from a research perspective. So there's still a lot of work trying to see how the Auger electron and the conversion electrons can be effective in cancer therapy. When we look at nuclides and how we go along and produce them, of course, you need to have large facilities to be able to make it happen. And to be able to do that, we go along and use the likes of research nuclear reactors. We use cyclotrons or linear accelerators, and even then what we call a generator, which was also mentioned a couple of days ago, like the germanium gallium generator. And these generators are actually produced via the use of a cyclotron or a research nuclear reactor. I'll touch on that in a moment. So your accelerated produced nuclides using cyclotrons or linear accelerators, which we like to term LINACs, they use particles such as protons or deuterons, or even gamma emission, like electrons, for the linear accelerator to be able to go and hit radionuclides and to produce the likes of fluorine-18, carbon-11. This is for your lower energies, gallium-67 for your medium energies, and even indium-111, etc. Electron linear accelerators can produce therapeutic nuclides. This is still under development, particularly at the places such as Argonne National Laboratory in the US. They're doing a lot of work there on being able to try and produce the likes of scandium-47, copper-67, even actinium-225, using what they call the Bremsstrahlung concept. Your cyclotrons that we go along and use at medical cyclotrons, medical facilities, those are your small cyclotrons, lower energy cyclotrons, and even your medium energy cyclotrons predominantly produce nuclides for diagnosis because they are neutron poor. The neutron rich ones then are produced at your reactors, and they are generally the ones that we would go along and use for therapy. Of course, there are exceptions to every rule. That's why I say generally, because that's what the trend is. And then your generator produced radionuclides are generally used for, well, some of them are used for therapy, like your actinium-225, bismuth-213 generators. And then you would look also at your lead-212, which is also then produced from a generator. That can be used for therapy, but predominantly they're also used then for diagnostic application. So what you go along and put on in terms of your target nuclide, the picture on the left, so your target nuclide then would be to your nuclide, that would be the target material you irradiate. Generally with medical cyclotrons, those are generally 18 MeV machines and less, sometimes up to 24. But these are an exception. And they would then predominantly put on the energy on the target that would be the equivalent of what they call a p-n reaction. One proton then shifts one neutron of the target material. And so for the likes of gallium-68 and copper-64 and scandium-44, they are all positron emitters. So the picture on the right then indicates how that would decay. It decays by positron emission, which is then the orange arrow then on the right-hand side. So it's almost like diagonally from each other in terms of what you put onto the target and to what it goes along and emits. The same here applies then for the reactor-based nuclides that are used with neutrons on targets. The target nuclide then gets irradiated with neutrons. predominantly the N-gamma reaction, which is the one to the right, that's the higher fluxes. The NP reaction is what they call fast neutrons. The N-gamma reaction is what they call thermal neutrons. And that then produces a radionuclide, which is on the right, which emits then predominantly your beta emission. And then just to go through to the electron linac, with the gamma irradiation, they generally put that onto what they call a converter target, which produces Bremsstrahlung. And the Bremsstrahlung then produces these nuclides that can either be alpha emitters or beta minus emitters predominantly. So this is what they are currently looking at to be able to expand on the therapeutic nuclide portfolio worldwide. So now if we have a look at these nuclides and how one is manufactured, you can see then, say for instance, for the neutron source or the neutron reactors, you can see all of these blue spots. These are the types of reactions that can happen on a target. As well as for a medical cyclotron, it's not just necessarily one reaction, it can be more than one. And this is where it becomes really very important to determine with your target material and the energy that you put on that target material, because you can produce side reactions. And the side reactions can produce other radioisotopes or radionuclides within your target material that you need to be able to separate from what you want to get out. It becomes a problem when your side reactions produce a radioisotope of that is then the same element of your desired nuclide, because when it is the same element, you cannot separate it chemically. And then this could become a side product that could be harmful to the patient and then would not be usable for patient application. So these type of things have to be taken into consideration already on the basic research side of things to determine what is feasible and what is not. So when one uses accelerators for radioisotope reduction, you generally need to use solid targets. There are exceptions, of course, where one uses liquid targets for, say, fluorine-18 production using enriched water, or even gas to be able to go along and produce the likes of carbon-11. But, you know, when it comes through to doing radioligand diagnosis, if you like, we generally have to use solid targets to be able to produce the desired radiometals. Now, as I've already started elaborating on what the product yield depends on and the product purity depends on, is a whole host of factors that we have to take into consideration. So it is the type of particle used for irradiation. Do you use protons? Do you use deuterons? Do you use Bremsstrahlung? And then the energy of those of the beam that you want to go along and put onto your target material. So how strong is that beam? And then based on that, and there is a very large section on the IAEA database as well that covers what they call cross sections of target material and cross sections of productions. And there one can go along and see, and this has all been done as part of basic research to determine when you use this specific target material to produce this specific nuclide, what do you get? This because some of them you can produce very high yields, but then you would also be able to produce other side products that you cannot get rid of. Other times you can produce much lower yields, but then the product is clean. So these type of things have to be taken into consideration, and this database really helps one be able to do that. Of course, then you have a lot of physicists and physics groups that focus on these type of reactions to be able to determine what can be produced. So the most popular reaction at medical cyclotrons, because there are so many of them worldwide, we can say the most popular reaction that is being used is what they call the PN reaction. So it's the lower energy protons on target material. And an example of that here would be, say, for instance, using enriched zinc-68, using a PN reaction to produce gallium-68. And that you would do at less than 15 MeV. Actually, closer to 13 MeV would be better, because of the fact that it can also produce the side product of gallium-67. And that is also based on the enriched target material that you use. So the other reactions that can also occur is generally then the P2 reaction. And so these nuclides that are produced using medical cyclotrons generally are also short-lived. They have a short half-life. Examples, actually the longest half-life of these would be, say, copper-64 that has a 12-hour half-life. Gallium-68 has a 68-minute half-life. Scandium-44 has a 4-hour half-life. Fluorine-18 has a 2-hour half-life. And carbon-11 is like 20 minutes. So generally short half-life. And this is good for diagnosis of the patient because having a short half-life radionuclide, then it minimizes also what is also a big topic nowadays, the dose to the patient. Okay, so this is a little table then that goes and covers basically what I've stated now over with the medical cyclotrons, what one generally goes along and produces. The ones in red are your radiometals that we focus on, and that generally requires what they call a solid target station. There have been liquid targets that have been used, and actually I've got colleagues in Portugal, in Coimbra, have done really a great job to be able to produce gallium-68 and copper-64 towards clinical trials using liquid targets. So hopefully for those that cannot be able to have the space to produce, have a solid target station installed, might be able to apply this in future. Then we also have your medium energy and your high energy cyclotrons. Your medium energy cyclotrons, these are between 30 and 70 MeV. Examples of this would be, say, for instance, Aronnax in France has a 70 MeV machine. PSI operates with a 72 MeV machine. There's a 70 MeV machine in the States, in the United States, that produces and focuses on strontium-82, for instance. So these devices are generally then focusing on the likes of germanium-68 production, which is also very important towards your germanium-gallium generators. Titanium-44 towards your titanium-44, scandium-44 generators, etc. And then your high-energy cyclotrons, and those are very few that exist. And it's generally just your large-scale research facilities that have machines that are greater than 100 MeV. And this examples of this is Brookhaven National Laboratory or Los Alamos National Laboratory in the United States. They would have these type of facilities. Okay, so I'm going to touch on concepts such as scandium-43 and 44, and because this is basically what I've been doing research on for the last 10 years. The target preparation, the encapsulation, the whole development from bench to bedside, how we've determined the cross-section measurement and the reaction that is required to be able to produce with protons. We've even done cross-section measurements actually with deuterons to try and produce scandium-43, and but of course the target material also becomes a problem. One has to take into consideration when we are doing these kind of things, when we want to be able to get it through to clinical application. An important part is how much does it cost to be able to produce? Because of course, we as the producers, we are not overly rich. We require it to be able to make it as cost effective as possible. And therefore also as well, at one stage, it's going to come through to a point where the medical insurance will have to go along and cover this. And so therefore this will also affect the patient in the long term. So we have to go along and try and make it available for everybody, and not make it such that it can only be made once or twice, and we can't really do it because it costs too much money. The same applies, of course, with nuclear reactors, because with nuclear reactors, they are generally very expensive to run, and they focus on predominantly the whole concept of nuclear fission. And this is where they use uranium nuclear fuel and use water and graphite then to be able to moderate the reaction. This is the chain reaction that normally takes place within the reactor. And it's based on this chain reaction that determines then what we call the neutron flux of the reactor. And so this is a little bit different in the sense that we actually take the targetry is vastly different. One has to produce target material and put it into a quartz ampule and seal the ampule. Then that ampule is sealed with generally with aluminium foil, and the aluminium foil is then placed into a capsule similar to what you see on your screen now, which is then sealed by means of electron welding. And that's just to ensure that everything remains totally sealed from a safety perspective. Now, it becomes a safety perspective in more ways than one, in the sense that they do not want the target to go along and explode and then damage the reactor. Of course, this is a big role to play. But then also at the same time, you don't want to be able to go along and have water get into your system. Your ampule also has to be checked and tested to ensure that it can handle that it's submerged for a period of time, and then that way it also shows that it is that it doesn't have any leaks within. So it's got to make sure that the ampule is also airtight or leak tight, if you like. So safety is a very, very big part of being able to produce nuclides, be it in a reactor, be it in a cyclotron. And to be honest, we don't really talk about it a lot. And we actually should talk about it a lot more, so that one can see what safety measures people are putting into play to ensure that this is done in a safe manner, because there's a great deal of uncertainty in the world of nuclides, because the word is radioactive, and radioactive has a tendency of scaring people. But in this case, we're using this now to be able to go along and treat patients. So, and to apply this, we need to do this in a safe manner. So with neutron fluxes, this depends on the type of reactor and how it's been designed. And the neutron flux also determines whether it's thermal predominantly or whether it is fast neutrons predominantly. We rely predominantly to be able to make therapeutic nuclides on thermal neutron irradiation. The neutron cross-section of the target material, and that depends from target to target. So you can actually go along and see on this screen for the black material. The black material is where this is natural abundance of the specific material. So that means it is not radioactive. And you can see there these sigma signs at the bottom end or the bottom left corner of your element. Say, for instance, like with the likes of gadolinium-160, the sigma value there is 1.4. And that's actually quite low. So this is what makes it a little bit difficult. If you have a look at, say, terbium-159, the sigma value there is quite high, is 23.8. So it's considerably higher what they call neutron cross-section. And so that depends from target material to target material. And so for the likes of gadolinium-160, because its neutron cross-section is quite low, you need a high neutron spectrum or a reactor with a high neutron flux to be able to produce decent quantities thereof. So this is where the cross sections also have a big role to play, is to go along and see what these type of reactions do. So the most common reactions are your neutron and fission reactions, as I showed before, and your N-gamma reaction. That is what you would go along and see to the right, say, with gadolinium-160. An N-gamma reaction indicates that with the green arrow that goes through to the one to the right, that shows gadolinium-161. That is your N-gamma reaction. And so in essence, by irradiating gadolinium-160, you are producing gadolinium-161. The disadvantage of using this type of route is many times one produces what they call carrier added product. The difference between that and what we do now for lutetium-177 as well as for terbium-161 is the reaction that it goes to. So in this case, gadolinium-160 goes through to gadolinium-161. But gadolinium-161 has a 3.6 minute half-life, and then it decays through to terbium-161, which has a 6.9 day half-life. So over a period of time, everything that is being made to gadolinium-161 is decaying to terbium-161, and therefore you have different your nuclide and your target material is different, so that means you can chemically separate it. In the old days where they were using lutetium-176 enriched to produce the N-gamma to lutetium-177, the problem there is that it is the same chemical element. So therefore, as a result, you could not chemically separate between the two, and they have to use it then as what they call carrier added product. That is now being phased out, especially seeing the use of ytterbium-176 is used instead of lutetium-176. So your neutron flux, your irradiation time, how much target material you use also determines then what product, and the enrichment of your target material, of course, determines your target yield and your target purity. So your nuclide yield and purity is determined by means of your enriched target material. This also has to be taken into consideration. And therefore, this is also the other thing. The higher enriched your target material is, the more expensive it becomes. So this also requires a totally different technology to be able to ensure that these materials are pure enough for us to be able to apply towards isotope production. So neutron reactors are used around the world, and particularly we have the likes of Safari in South Africa, BR2 in Belgium, and the likes. We've got ILL in France, we've got Maria in Poland, etc. And they produce technetium-99 from molybdenum-99. They have technetium-99M that is produced in form of a generator. But these reactors produce enough for 40 million patient doses per year. So it just goes to show that, I mean, this is still extremely valid. Of course, there was 20 years ago, there was a massive problem, or was it 25 years ago now, there was a massive problem where there was a shortage of the molybdenum-99 production because of the fact that there were too few reactors operating. And one then came to realize how important this is towards patient diagnosis. So the use of these reactors is very, very important. The problem that we face nowadays is that these reactors are pretty old, and so more of them are being retired than we are building new ones. But I must say, out in Asia, there is a lot of work that's being done in being able to build more research reactors towards medical radionuclide production. The United States is looking at now being able to build a few more too. So let's see what happens over the next couple of decades. So the ampule that I was telling you about in terms of the quartz ampule with the target material is the picture there on the left in terms of the gadolinium oxide that we produce for terbium-161. I'll touch on how we go about doing that a little bit later. This is just the whole concept then of using neutron fluxes and different neutron fluxes and different irradiation times to be able to go and produce the desired radionuclide. And of course, then logistics also comes into play as well, because not all of us have nuclear reactors in our backyard. So it becomes such that we actually have to send the ampule away for irradiation. We have to receive the ampule back to be able to go along and process. And so from this perspective, it becomes important. So the reactor cross-section then is basically your flux and your particles coming in through to your target material. And basically, the concept is that it's measured in barn or millibarn, and it is then the likelihood of that specific element being impinged upon by the incoming particle, be it neutrons or protons or deuterons, etc. And then that way, how many of those will go along and react and be excited? And one can go along and do this with different energies, and one can see here, and this is just an example, and the main reason why I'm touching on this is because based on the enriched target material that we have, this is now for terbium-155, we have target material like gadolinium-155 or gadolinium-156 that is 91 to 93% enriched. And that's pretty cool. I mean, we can go along and produce terbium-155 via the PN reaction using a medical cyclotron, or P2N reaction using the medium energy cyclotrons. And the point here, though, is what happens to the 7 to 9% of non-enriched material. That means it implies that there's other gadoliniums that are there, and the other gadoliniums can go along and produce side products such as terbium-156. And so terbium-156 now versus the terbium-155 that we want to use, it's an Auger emitter. It has low energy gammas. We can use it for single photon emission computed tomography, or SPECT, for imaging. And so it's a pretty cool isotope, and it's got a 5-day half-life. But terbium-156 has higher energies that really go along and can interfere with any of your imaging. So it'll really go along and mess with the image quality because of the excess noise. It has the same half-life as terbium-155, so we can't wait for it to decay away before using the terbium-155. It stays with it. And so the 156 becomes a big problem. We have to minimize that as much as possible, but that comes from enriched target material and the reaction in play. So using the PN reaction on on gadolinium-155 actually produces less terbium-156 than using the P2N reaction on gadolinium-156, even though you produce more terbium-155 that way. So this is where you have to go along and determine which is the better option. Of course, right now at this stage of the game, this is still in development stage and still being determined then as to how much terbium-156 is the maximum one can have towards, say, potential patient application in terms of dosimetry to the patient, as well as how badly does it interfere with the image quality of the SPECT image in question. So this is still something that needs to be looked at. So when one looks at target irradiation, and this is also a question, why do we produce so much more in a reactor than we do in an accelerator? And the reason for that is when we actually put our target material into a cyclotron, a small beam, a pencil beam, will then go and hit our target material. And if you can see the picture on the left, you can see that not all of the target material is irradiated. So it's only part of the target material that's irradiated. If we have to take that same mass and we stick that into a nuclear reactor for a period of time, of course, now with a reactor, they irradiate for much longer. They irradiate for days. Generally in a cyclotron, it's also only for hours. But the reactor core surrounds, or the neutron flux surrounds, the target material in its entirety. So basically the entire target material is then exposed to the neutron flux for a period of days. So there's an abundance of activated neutrons, whereas more on the cyclotron side of things, there's more an abundance of target material over the particles that are impinging on it. And this is also why one has so much more in terms of a yield from reactor-based material. So when one is talking about, say, for instance, producing scandium-47, and a lot of work is being done on seeing what it can be done with a cyclotron, the yields from a cyclotron is going to be considerably less than what you would get from a nuclear reactor. And then one also has to take how many patient doses into consideration. So looking at nuclides via a generator system, I'm not going to spend too much time on this, but the whole concept, and I mean, the whole concept was described earlier on this week practically with their projects. But the whole concept then is where one produces a specific nuclide by proton irradiation or neutron irradiation, depending on what you want. In this case, I'm going to say, let's focus on germanium-68. And let's say germanium-68 is the parent nuclide, which is A. So you irradiate a gallium target with protons to produce germanium-68. The germanium-68 then will be placed and loaded onto a substrate where it can stay, and it will decay through to its daughter nuclide. And the daughter nuclide generally has a much shorter half-life than the parent nuclide. In this case, gallium-68 will be B. And gallium-68 is then got a 68-minute half-life, where germanium-68 has a 9-month half-life, 280-day half-life, so considerably shorter. And then gallium-68 will in turn decay through to C, which will be then zinc, which will be stable. So this is the concept that what one tries to go along and apply into a generator system, because then that way you can, when you produce the generator and make it available, it then can go and be able to decay into its daughter, which is then the gallium, and which you can elute from the generator over a period of time, but also ensuring that the parent nuclide stays on the substrate. This is the important part. It mustn't come off with it, because then otherwise you cannot really use it effectively. So this is the concept that one goes along and uses, and generators have been used quite effectively in nuclear medicine over the years. So you have the likes of your germanium gallium generator, of course, your molybdenum 99 Tech 99M generator. Those are your two more popular ones that you would go along and look at. And so these are the generator systems that one can go along and produce. I'm not going to go into detail as to how one calculates the activity of the daughter, because of the fact that some of them are not easily. So say, for instance, with your germanium-68 and your gallium-68, the time that it reaches secular equilibrium is, say, 7 hours. But using the chemical capabilities of the acid in question to be able to elute the gallium, you don't elute all of it off. So generally you have then, say, a 65% yield over that. So the different production methods, as a quick summary, is basically the concept of using the accelerators or cyclotrons, using charged particles like protons and neutrons to produce your nuclides. Generally, they are proton-rich nuclides. Then you have the concept of a heavy target spallation that I haven't really touched on, because that is seriously exotic, predominantly used for nuclear physics, but we are trying to apply this now towards medical isotope production as well. But that's another topic altogether. We have then neutrons from reactors, and they generally produce your neutron-rich nuclides, which are then used predominantly for therapeutic purposes. Okay, so I'm now bombarding you with all sorts of information. I do apologize. But I'm hoping that it will provide you with some good insight as to the world of isotope production. Now, I'm going to say, how does one actually produce a nuclide from scratch? And there are certain things that one would go along and look at. You would look at the desired nuclear reaction. Can we go along and do this? And using a specific type of target material. So you have to look at the target material and the nuclear reaction, and then based on that, look at the cross-section or the excitation function. You can go along and look at that, say, for instance, on a database to see if this is possible. If not, then sometimes you have to even go along and produce your own data. And then, of course, that's, you know, more time that one needs to go along and spend on your experiments. So your target material then, if you decide that this is the reaction that you want to pursue with this target material, then you have to determine how well will it react in radiation conditions. Will it be robust? Will it be able to go along and take these extreme conditions? And then after that, you have to determine, can you actually dissolve this target material to be able to apply it towards chemical processing under specific chemical conditions? So that target material has a great deal of responsibility. It has to be robust in the beam. It has to be dissolved towards being able to get your nuclide out. So to be able to do this also in terms of your chemical separations, there is what we call a setup with regards to resins, our ion exchange resins that I was mentioning, how we perform these chemical separations. And to be able to do that, there's a database, well, a literature base where one can determine distribution coefficients. Sometimes there are no distribution coefficients available and you have to do your own experiments. But the distribution coefficient determines how well your resin, under certain conditions, will be able to retain a specific element. And based on those numbers and based on that data, you can try and determine and devise a chemical separation process under specific chemical conditions to be able to get your desired nuclide. I will give you an example. So based on this, you can then test and design your experiment. And then after that, you can start, this is all done cold, non-radioactive. So this way you can also then be able to go and test using your analytical devices like your ICP to determine how well things are going in terms of your chemical processing. Once you are up, confident with your results, you can devise a method to be able to then spike with a little bit of radioactivity. Once you are happy with those results, then you can devise and build a chemical separation system, which you would then test, and then you be able to go along and apply that into a hot cell environment and then do test runs and start upscaling, etc. So it's quite the challenge to be able to get it from the concept of a little idea into a hot cell for initial irradiations and separation. So this is what we've gone along and done in the case of scandium, the whole concept then is also looking at the specific cross section, and the cross section here for scandium, looking at calcium, we would then irradiate with protons, and you can see at around about 10, 11, 12 MeV, that's where we get some pretty high scandium quantities. We start producing an impurity in scandium 43 at around about just shy of 15 MeV. Now, to be able to produce something for chemical application, you generally want it to be radionuclidically pure, and that implies then you cannot go along and operate your cyclotron at anything more than 14 MeV to ensure that you have radionuclidically pure product. So that's what we focus on. Okay. However, of course, if you go along and want to produce scandium 43, which is supposedly the impurity, now in this case, it becomes really interesting because scandium 43 is also a positron emitter. It has the same chemical properties as scandium 44, except it doesn't have the high gamma that is associated with scandium 44. The only problem with it is it's far more difficult to make. It's far more expensive to make. And so therefore, while scandium 43 people look at and say, oh, that would really be very, very nice, it becomes very, very difficult for the likes of us to be able to produce on a regular basis because of the cost related to it. The target material, for instance, with scandium 43, if you have 58% enrichment, that means you're going to make scandium 44 anyway. So you need to have a high enrichment. And as soon as you have a high enrichment, then you start looking at about 150,000 euro per gram of target material. And that's, well, we can't afford that. So it becomes really, really very difficult to be able to say, oh, this is the good reason for us to do it. Okay, so now this is actually distribution coefficients that was put out by Pomont and Dauphin some years ago. And this is where they used and they did distribution coefficients. These guys actually worked at ICROM. And developed this resin, which is an extraction resin, a DGA extraction resin. And they did 60 distribution coefficients, 60 different elements, and they did it in various concentrations of nitric acid as well as hydrochloric acid. So this was a lot of work. Anyway, so Now we're going to be looking at the likes of scandium and calcium. Scandium, unfortunately, there's no data here, but if you look just below it, you can see that yttrium is there, and yttrium indicates that it has a very, very high distribution coefficient. So in essence, it doesn't matter what concentration of nitric acid you go along and use, it will be retained. So now you take that into consideration that this would be the same for scandium. But for calcium, however, if you start using higher concentrations then of your nitric acid, you can then be able to go and decrease it. So you can go and be able to rinse it through the resin column. So this is what you would look at, but also you have to also think about the other potential impurities, the chemical impurities that we were talking about that could hinder your labeling. So the most popular ones being, say, the likes of copper and zinc and iron. So if you look at iron, for instance, that has a low distribution coefficient at around about 1 molar nitric acid. And then the likes of zinc, the same applies. So if you use 1 molar nitric acid, then to be able to, you take your target material, you irradiate it, and you would then dissolve it using 1 molar nitric acid. And then you take that solution and you pass that through your DGA column, resin column. You will see that scandium, your scandium is strongly retained, your calcium, some of it goes through, some of it is left behind, but your iron and your zinc are not retained. They go right through the system. So already you are taking and getting rid of your chemical impurities as part of this initial separation. But now you've got your scandium on your resin, and you've still got some half of, say, for instance, half of your calcium on the resin. What are you going to do now? So if you go through to what these gentlemen did for DGA and hydrochloric acid, then you can go along and see that the likes of, if you look at, say, for instance, the yttrium side of things, it means that with your low concentration of HCl, the distribution coefficient is low. That means it comes off the resin. It'll come off very easily. If your distribution coefficient is high, then it implies that it doesn't come off the resin retains it. So in this case, with scandium around at low activities, at low concentrations of HCl, it will come off. The same applies then through to calcium. And then, of course, if you have a look at your setup with regards to shifting it to 3 molar HCl first. So, of course, your scandium, if you look at the yttrium side of things, the 3 molar, it is well retained. So your scandium is still going to stay on the resin. But if you look at your calcium at 3 molar HCl, it is pretty low. I mean, calcium is pretty low in HCl anyway. So then that way you get the best of both worlds. Your scandium is maximized, your calcium is minimized. That means when you pass your 3 molar HCl through the resin, now you've switched it from your nitric acid, your calcium is now going to come off, but your scandium is still there. Your scandium is now stayed on the resin, your calcium is off, and of course, your iron and your zinc are already been shifted and taken off, and then you can finally switch then through to 0.1 molar or 0.05 molar HCl, which is what is desired then for preclinical or clinical application to be able to take your scandium off into what you want. So there you go. You've now gone along and created your own chemical separation with scandium and calcium. So irradiating calcium, being able to produce your scandium. So you devise your system, your chemical separation system, to be able to go along and first have your DGA resin that does all the work for you to be able to go along and produce, to separate your calcium and scandium, as I've described before, using either your nitric acid to dissolve and pass through the resin. You rinse it then with your hydrochloric acid, and then take it off in your HCl as well. And then we have what we call a column for concentration purposes, and then you would be able to load that onto the column and be able to take it off in a small volume for preclinical application or clinical application. In this case, this one with the SEX column, this one is being focused then on the clinical side of things. So again, targetry, it becomes an important thing. Your target material is important. And so initially where we started, we had calcium carbonate to go along and begin with, enriched calcium carbonate. But with the conditions, the irradiation conditions, it generates heat. You can just imagine with the speed of protons hitting a target material, it generates a lot of heat. The targets need to be cooled, and generally are cooled then with either, well, some gas behind and water in the front, or water from the front and behind, depending on your systems, your target systems. And then this way, we found that if we switch to calcium oxide, it becomes more robust, and it ensures that the target material does not go along and dissociate in the beam, and you can be able to produce your nuclide effectively. And this has been applied now preclinically, and has also been used first in human applications. And I know, well, from our perspective, we'd be looking at trying to then translate this to clinical trials in the near future. This would be an aim. From a terbium-161 perspective, again, now we've used the ampule preparation. I've mentioned this before. We've sent it away through to the site. Depending on the facility and the neutron flux produces various quantities of activity, it gets flown back through to us, and we have performed the chemical separation. The chemical separation here is different. Because it is now lanthanides separation from lanthanides, becomes a far more difficult situation. In this case, one can either, we've done this before initially with either evaporating the target material and then passing it through our cation exchange resin. But in the case of terbium-155, what we've done here is we've first done an initial separation with extraction resin. So again, taking away some of the target material. The main bulk with the big column then ensures that the terbium is separated effectively from the gadolinium using different concentrations of alpha hydroxy isobutyric acid. So it's not hydrochloric acid, it's not nitric acid. This is now a different separation system. And this was a different development because of the different elements and the different chemical environment and irradiation environments. So all of this has to be taken into consideration. The concept of using another extraction resin then for concentration purposes is performed. From this perspective, we're just looking at cleaning it up and polishing it up and actually finally eluting in 0.05 milli HCl. But this one is quite cool in the sense that one can even perform if there were any slight traces of gadolinium, it would be separated then from this in this setup. So we've managed to label this at 100 megabecs per nanomole, and my colleague Christina Müller here at PSI has done excellent work, of course, to indicate and show how effective terbium-161 PSMA is over the likes of lutetium-177. And this has also allowed us to be able to pursue the concept of a clinical study. I know I'm now running a little bit late, so I'm just going to touch on this and say we have to develop then a protocol to be able to apply the labeling capability into the GMP processing system. And this is what we ended up going along and doing as part of preparation then for a clinical trial. And two of them have been underway here at in Switzerland that we've been involved in. And initial results have been published, and there've also been an excellent initial result done in Australia with regards to the Violet study, which has used much higher activities of terbium PSMA, and the results look particularly promising. So this is now showing how we can perform this in a clinical environment. My take-home message from my perspective as a radiochemist is it doesn't matter what target material you use in terms of its preparation and how you go along and irradiate it. Without chemical separation, you are not going to be able to get your product out and available for either preclinical or clinical applications. So it is a vital part of the process. But one cannot go along and emphasize enough that without all of these things in play, and with collaboration, we are not going to be able to get the success that we would like. It takes time to optimize these things. One has to be ensure that new facilities and operating these facilities and optimizing them are required. We need specialized teams to be able to make all of these things happen, working together, and to be able to go along and get such a facility up and running, and with these people that you collaborate with. It generally, at this stage of the game, to take a new nuclide from the bench, from the experiment through to the patient, is now taking approximately 10 years. And now that this is happening more and more, I'm inclined to think that policies and things will be streamlined, that maybe that this time taken to be able to go from bench to bedside will be shortened. So that concludes my presentation, and yeah, I'm open to questions. Thank you for listening.
Questions? Nick, thank you very much for such a nice presentation. I couldn't see, I mean, what was the energy of proton PN for the PN reaction on gadolinium to produce the terbium?
So yeah, so when one uses gadolinium 155, yeah, the optimized, we generally use around about 11 MeV, but the sweet spot would be around about 13 MeV.
13 MeV, that's,
yeah, 13, yeah.
reasonable.
Yeah, if you go a little bit higher, then yeah, generally for the radiometals and the PN reactions, a good general rule of thumb is, you know, you get the best results, even for, say, gallium-68 production, terbium-155, scandium-44, 13 MeV is not bad.
Okay, okay. Regarding the evaporation of the calcium carbonate for the scandium, I mean, did you use any type of water cooling or similar type thing to, you know, to ignore the evaporation of calcium?
Yes, so generally what we did was our target material is always encapsulated. So, and with the capsule, then we would cool on the outside of the capsule during irradiation. So generally with water. Of course, with the smaller cyclotrons, you would then say, for instance, also have helium cooling. So maybe helium cooling from the front and water from behind.
Yes.
And this is effective. Of course, the problem that you have is that the carbonate, because it still generates heat within, and it can, and it also depends on the capsule that you use and the like for the sealing, but it can go along and dissociate where the carbonate then becomes carbon dioxide and oxygen, and then your target then your capsule bulges. So it's actually far better just to be able to prepare the carbonate beforehand, heat it up through to 500 degrees, and then ramp it up through to 800 degrees Celsius to be able to convert it through to oxide, and then let that cool, and then prepare your target and run it. Okay, thank you. Any other questions?
Okay, I see another one. I mean, asking how cost effective it is, I mean, in terms of considering the marketing of the products.
It depends on what you're looking at.
Well, I mean, in terms of, for example, when you consider, okay, terbium is clear, but for the scandium one, I mean, compared to the current products, I mean, how cost effective it is, they are asking.
It requires investment. At this stage of the game, what will make it cost effective will only be determining the size of your target versus, so in essence, you get a gram of calcium, enriched calcium. You have to determine then, depending on your patient demand, as to how much you need to produce. From there, you can then go along and determine based on that and your irradiation time and the size of your target. So what we've currently done, and I can tell you this, we've published this already. So if you irradiate, say, at 50 microamps for 90 minutes, you can produce up to, say, 3.5 gigabecs from a 20 milligram target. And then, of course, that works out to what, 20 patient doses or so, taking this into consideration. So then this works out to the target material would cost you about €700, but you get to recycle it. So it's not lost, you keep it,
Yes.
and then you can recycle it. So if you don't recycle it, it's not cost effective at all, but you have to recycle to make it worth your while.
Okay. No, that was great response. Thank you. Any other questions or comments? Okay, just one more.
Not directly, but what is your comments regarding toxicity of scandium for clinical usage?
I'm sorry, I didn't get all of that.
The toxicity of
Toxicity.
scandium for clinical usage.
Okay.
Your comments
Well,
regarding this?
yeah, I mean, the toxicity obviously would have to be determined still from a GMP perspective. I mean, a tox study would have to be performed, but preclinical work has been done on this. And so from that perspective, the toxicity is well handled. Scandium is very lanthanide-like. So it would be similar then with regards to the use of lutetium and terbium. So from this perspective, a toxicity issue is not foreseen. But of course, needless to say, you still have to demonstrate it.
Of course, yeah, for GMP. Okay, I think we are summing up. Okay, thank you very much, Nick.
Thank you.
Hope to
Thanks
see
for
you
having me.
sometime in Izmir or in Istanbul, okay?
I look to return. Thank you very much.
Thank you. All
Thanks.
the best.
Thanks to you too.